So, hello everyone. Let's begin the discussion on a very important topic that is out of these cardiomyopathies, often the favorite subtopic of examiners, that is the hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. So, this is a very important module, I would say, because each and every aspect of this module is a potential question. Because I already told you, if an examiner is asked to frame a question from cardiomyopathy, most likely the question comes from hypertrophic cardiomyopathy. Such an important topic. Now, why is this such an important topic? Let's try to see its relevance. So, in the relevance itself, the first MCQ point is that this disease, hypertrophic cardiomyopathy, is the most common genetic cardiac abnormality. Okay, most common genetic cardiac abnormality is hypertrophic cardiomyopathy. Very important. So, the prevalence of this condition, hypertrophic cardiomyopathy, especially in the North American, Asian, African population, the prevalence comes to around 1 in 500. Okay, so that is the prevalence of hypertrophic cardiomyopathy. And another potential question that can be asked from this is that this hypertrophic cardiomyopathy is the most common cause of sudden death in young adults. Most common cause of sudden death in young adults. So these two are potential questions. Okay, very important. All right. Okay. So moving ahead, trying to understand the topic better. Okay, let's try to understand why does an individual develop hypertrophic cardiomyopathy? That is what we are going to learn. So hypertrophic cardiomyopathy, please understand that this is predominantly a genetic condition. Okay, we have already seen that it is predominantly a genetic condition, and the pattern of inheritance is autosomal dominant. The pattern of inheritance is autosomal dominant. So what is the gene mutation that is responsible? Let me tell you, it's not a single gene. There are multiple genes that are involved, any of which could be involved in hypertrophic cardiomyopathy. So the bottom line is hypertrophic cardiomyopathy occurs because of mutation in the sarcomeric genes. Okay, it occurs because of mutation in the sarcomeric genes. Very important. Now, if you ask me specifically which sarcomeric gene, first of all, let me scare you by a picture. Okay, you see this. Okay, so in the sarcomere there are lots of genes, and all these gene mutations can result in hypertrophic cardiomyopathy. So you see all these genes which are mentioned, all these can produce hypertrophic cardiomyopathy. But you do not want to learn all these genes except for two genes. Those are the two genes most important, often asked by examiners, and that is this gene and this gene. That is, one is the beta myosin heavy chain gene as well as the myosin binding protein gene. Okay, these are the two genes which are most important. So because why are they most important? Because they are the ones most commonly implicated. So if you are asked regarding the most common genes implicated among all these numerous sarcomeric gene, one gene is the MYH7 gene. Okay, that is a gene that codes for beta myosin heavy chain, and the next gene is the myosin binding protein. Okay, MYBPC3. Okay, that is the myosin binding protein. Okay, the myosin binding protein gene, that is this MYPC3. Okay. Now, if in the exam they are asking you to select the most common one, Actually, my answer would be both of these are equally common. That is what the data tells us. But for your exams, if a single gene is asked, always go for MYH7. Okay, slightly more common than the other one as per some literature. Okay, all right. So you have understood the genetic mutation also, very, very important. Okay, so as a result of this gene mutations, what will happen? You understood there is some gene mutation. What is the end result? The end result is that there is hypertrophy. So if you ask me what exactly is this condition, hypertrophic cardiomyopathy, my answer would be, see, this is a condition that is characterized by hypertrophy of ventricles. Okay, hypertrophy of ventricles. Now, if you ask me which ventricle, often it is the left ventricle. Okay, much common than the right ventricle. Rarely the right ventricle may be involved, but predominantly it is a condition that is characterized by hypertrophy of the left ventricle. But then you may ask me a question. Sir, you're saying that hypertrophic cardiomyopathy means there is some left ventricular hypertrophy. But I have learned that because of hypertension, aortic stenosis, all these can also result in left ventricular hypertrophy. So is that also included in this domain of hypertrophic cardiomyopathy? My answer is, see, that is not included under hypertrophic cardiomyopathy because the definition is not complete. Whatever I've written here is not complete. Yes, there is a hypertrophy of the ventricle, but that should be in the absence, or it should be disproportionate to the hemodynamic factors. That is, in the absence of other hemodynamic factors, like what hemodynamic factors am I talking about? Like your hypertension, or aortic valve disease. So these ideally should be absent, or even if it is present, maybe some individual is having hypertension, because see, hypertension at the end of the day is a common medical condition. So it is possible that somebody with a hypertension, manifest hypertrophic cardiomyopathy also. But if the hypertrophy is out of proportion to the hypertension, that is when you can probably attribute, okay, is this or am I dealing with a case of hypertrophic cardiomyopathy? So this particular definition is very important, where you have hypertrophy of the left ventricle in the absence or disproportionate to the hemodynamic factors like hypertension, aortic valve disease. And also you can add, okay, in addition to this, you can also add without or like absence of infiltrative or storage disorders. Okay, infiltrative or storage disorders, which also sometimes can mimic a hypertrophic cardiomyopathy. So that is also important. This point is also important. So that makes it a complete definition of hypertrophic cardiomyopathy. Okay, all right. Now let's see more details about hypertrophic cardiomyopathy. And let's see what actually happens. I already told you there is a hypertrophy. But remember, the hypertrophy that occurs in a hypertrophic cardiomyopathy is not a symmetrical hypertrophy. Okay, it is not just like any other hypertrophy. And how does it occur and what are the hemodynamic impacts of the hypertrophy? That is what we are going to learn up next. So I'll take your attention to this diagram. So this is on the left hand side, what you are seeing is a normal heart. Okay, and this is one with a hypertrophic cardiomyopathy. So what are we trying to understand? We are trying to understand what is happening first in a hypertrophic cardiomyopathy, and then we will see the hemodynamic effects of this structural change. So you see here, this is the left atrium. Okay, this is the left atrium, this is the left ventricle. So this is the outflow tract, that is the aorta. Okay, you can see the aorta. That is, you have the outflow from the left ventricle to the aorta. And what you are seeing here, okay, this will be your aortic valves, okay, the aortic valves. And then what you are seeing here is the mitral valve, okay, the mitral valve here, okay. So these are the important structures that you should know in this picture: the LA, the mitral valve, okay, the LV, the aortic valves, the outflow tract, the aorta. So this is the normal, and let's see what abnormality is actually happening. Okay, so first of all, the abnormality that happens, okay, in this picture in the right side, hypertrophic cardiomyopathy, I'll just write here. First point is that there occurs asymmetric septal hypertrophy. Okay, asymmetric septal hypertrophy, okay, involving the left ventricle. Because if you see here, the you see here, this is the region of the interventricular septum. You see there is so much of hypertrophy. Compare with the other side, you can see there is so much of hypertrophy. So it is not a uniform hypertrophy that happens. So there is a asymmetrical septal hypertrophy, okay, and there is an increase in the thickness, the muscle wall thickness increases, okay. And do not think that just because you have an increase in muscle thickness, you're going to have a very strong heart. That is not actually what happens, which we will discuss once we come to the hemodynamics. But anyway, for the time being, there is some increased muscle mass there. But you may ask me, sir, in the picture I am seeing that this part is also slightly hypertrophied. Yes, there is a hypertrophy of the free wall. Okay, you can call it the free wall. So there is also a hypertrophy of the LV free wall. Left ventricular free wall hypertrophy is also there. But the most important point that you have got to know, it is always a septal hypertrophy, which is much more than the free wall hypertrophy. Okay, LV free wall. That is what I mean. Left ventricular free wall. So there is hypertrophy happening. Very important, and it's a asymmetrical septal hypertrophy. See, this particular pattern is the most common pattern of hypertrophy that happens. Okay, most common pattern of hypertrophy that happens, because rarely you will have certain other patterns of hypertrophy like apical, concentric. All this also can be seen rarely in hypertrophic cardiomyopathy, but remember, rarely. So the common one is the asymmetrical septal hypertrophy. Very clear. Now, in addition to the asymmetric septal hypertrophy, first of all, you know what is the end result of such a hypertrophy? Huge increase in muscle mass over the septal region plus free wall hypertrophy. What will happen to the cavity of the left ventricle? There is a decrease. Okay, there is a significant decrease in the left ventricular cavity size. Okay, LV cavity size. This is very important. Again, is very important in understanding the hemodynamic effects. So you are very clear with one fact: the cavity of the left ventricle is very small. Clear? All right. Now, what happens next? Okay, that is what we are going to learn. See, once there is hypertrophy of the septal region and the free wall, that is not alone what contributes to the hemodynamics. There is something else which is very important. Because one very important terminology regarding hypertrophic cardiomyopathy is that in hypertrophic cardiomyopathy, there occurs dynamic LVOTO. Okay, what is this LVOTO? It stands for dynamic left ventricular outflow tract obstruction. So this term left ventricular outflow tract obstruction is important, but more important is also the term dynamic. Okay, and I'll tell you why it is a dynamic obstruction. Okay, so it's a fancy term, right? You know, dynamic left ventricular outflow tract obstruction. Let's try to understand why. See, when there is a hypertrophy of the ventricles, along with that, there also occurs, okay, in addition to this, there also occurs something that is known as SAM. Okay, very, very important point. What is it? SAM. And what is the SAM? It stands for systolic anterior motion. Okay, systolic anterior motion, that is your SAM, systolic anterior motion of the anterior mitral leaflet. Okay, of the anterior mitral leaflet. So the point is, during the time of systole, the anterior mitral leaflet, what it does is that it has a anterior motion, and ultimately this anterior motion of the mitral leaflet makes it actually the mitral leaflet very close to the interventricular septum. So if you just focus here, this is the region of the mitral leaflet, and when there is a hypertrophy and during the systole, what happens is that this valve, okay, mitral valve, is closely opposed to the hypertrophied interventricular septum. Okay, they come very close to each other. So are you seeing this? That is, when this particular mitral valve leaflet reaches close, are you able to appreciate one fact that the orifice, okay, or this outflow tract is very much narrow? You see, compared to the normal picture where you had a very good outflow tract, okay, you see here there was good space and there was a good outflow tract. Here what happens is that the outflow tract is very much narrowed. So this narrowing that actually happens because of the, and this narrowing especially happens when there is a SAM. Okay, so it is when there is a SAM, there is a dynamic left ventricular outflow tract obstruction, dynamic LVOTO, dynamic left ventricular outflow tract obstruction. And that dynamic left ventricular outflow tract obstruction is responsible for most of the hemodynamic effects of a hypertrophic cardiomyopathy. Very important. Okay, so you understood what is SAM and how does SAM contribute to the hemodynamic effects. Okay, and also remember one point, that this hypertrophic cardiomyopathy, okay, so it has certain other names, in fact old names. Currently we use the term hypertrophic cardiomyopathy. So previously we used to call it by certain names, okay, but now those names are per se not used. One is ASH, okay, that is a asymmetric septal hypertrophy. Yes, it occurs in hypertrophic cardiomyopathy, but as such the term alone for this condition is not used now. Okay, asymmetric septal hypertrophy. Okay, that is one term. Next term is IHSS, which stands for idiopathic hypertrophic subaortic stenosis. Now this term is also very important. The first term I am sure that you already know why. See, the second term, it is a hypertrophy and it is a subaortic stenosis. Because if you notice here in this particular picture, see, the green one is the aortic valve, which I am highlighting now. So when there is an outflow tract obstruction, remember it is the outflow tract obstruction occurs not at the level of the aortic valve, it is a subaortic region. Okay, this is the region where I'll just highlight with this pink one. So this is where the outflow tract obstruction happens. So it is a subaortic region where you are having this stenosis, or in fact a obstruction. So that is also another term. And also another term that was previously used was HOCM, which stands for hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy. That was another term that was used. But now this term obstructive is taken off. Okay, the O is taken off. So why this is taken off is because I told you this is a condition. Hypertrophic cardiomyopathy is a very common cardiomyopathy. And everyone with a hypertrophic cardiomyopathy may not have a significant obstruction. Okay, So if there was significant obstruction in vast majority, then the mortality rate would have been more higher. Okay, so the term obstructive is not used because it is actually a hypertrophic cardiomyopathy with or without obstruction. You may or may not have an obstruction. Okay, important. So these are the terminologies that you should know. Okay. So after having understood the terminologies, let's just have a look at a gross image. Okay. I'm sure you are able to appreciate there is so much of a hypertrophy that is involving the septal region. Also, there is some free wall hypertrophy also that you are seeing. Okay. Very, very important. And another point that you should know is that, see, remember I told you the cardiac muscles, they are actually, hypertrophic. I told you do not expect that that is going to increase the efficiency, because though there is a increase in this actual muscle mass, it is not an effective increase in muscle mass that you see in hypertrophic cardiomyopathy. Now, why is it not an effective increase? I'll just show you with this help of a histopathology of the cardiac muscle of a patient with a hypertrophic cardiomyopathy. See, what you can see is there is a complete myocyte disarray. Okay, it is not arranged in a usual systematic manner. So it is a myocyte disarray, a complete myocyte disarray. And normally all these muscle fibers, they would be arranged usually parallel. If you remember your lessons, your physiology lessons where you learned regarding the cardiac muscles, they're arranged, very much parallel. But here, it's almost like all these crisscross arrangements. Okay, all these crisscross arrangement of these muscle fibers which you can see, and because of which it is not an effective increase in muscle size. Okay, it's almost like the muscle size is increased without a gain to the body. And in addition to the muscle size, you also will have interstitial fibrosis also. So you will have fibrosis also developing in the cardiac musculature, again contributing to the ineffectiveness of the cardiac muscles. Okay, so that is very, very clear. Now, having understood in detail regarding why a hypertrophic cardiomyopathy happens and what is the hemodynamic impact. Okay, so now let's go more and understand what actually happens, how does a patient clinically present, and then what are the examination findings. So I told you what is going to happen is often because of your dynamic left ventricular outflow tract obstruction. That is what will cause all these manifestations. And please understand that, remember I told you the left ventricular cavity size is very much shortened, and because of which, what type of cardiac failure are you expecting in a patient with a hypertrophic cardiomyopathy? Is it a systolic failure or diastolic failure? Remember, it's a small left ventricular cavity, so the left ventricular filling pressures would increase. So it is actually a diastolic failure that occurs. Okay, remember, it is a diastolic failure that occurs. Yes, in late stages you can have systolic failure also, but very, very important, it is the diastolic failure that is the hallmark of a hypertrophic cardiomyopathy. Okay, very, very important. And when there is a diastolic failure, what happens is, see, when the left ventricle is not able to accommodate enough blood, what will happen? There is back pressure on the left atria. So there is an increase in the blood in the left atria, and subsequently what will happen? The left atrium will hypertrophy. So the left atrium will hypertrophy, it will somehow try to eject blood into the muscular left ventricle. So the left atrium also undergoes hypertrophy, and once it cannot compensate, what can happen is that there can be a pulmonary edema as well, because there is a back pressure, increase in hydrostatic pressure, and then subsequently a pulmonary edema would result. Okay, so that is what happens, and that is the hemodynamics of hypertrophic cardiomyopathy. So with this in mind, let's move on to the clinical features, because only then we'll be able to understand how the patient actually presents to you. Clinical features. So about the clinical features of hypertrophic cardiomyopathy, See, many patients would actually remain asymptomatic. Okay, they remain asymptomatic, and if the patient presents symptoms, it is usually in the adolescents, or you can have young adults. Young adults. There is no definite sex predilection. It is almost like males is equal to females. Now, when symptoms arise, let's see what are the important symptoms. So, one is that patient can have dyspnea on exertion. Dyspnea on exertion to begin with. Dyspnea on exertion. So, patient would have exercise intolerance. Often, I told you it can be seen in case of adolescents and young adults. So, if you have a adolescent male or a female, maybe of the 20s, who are not able to be at par with the others of the same age group, maybe they are playing some sports. So they see that, whenever they are exerting a bit, they would actually find them incapable of doing that. So there is an exercise intolerance also. So you can have dyspnea on exertion, you can have exercise intolerance. So it may not be even a severe exercise, even a very minor exercise, just like walking or a climbing stairs, they might actually feel breathless. Okay, so that is because of which one of the complaints they initially say might be, which might not bring them actually to the doctor, but still, they would say that, see, I'm not able to be at par with my colleagues, whether it be I'm walking or playing some sports. So dyspnea on exertion, exercise intolerance are important presenting symptoms. You can also have excessive fatigue. Okay, you can have palpitations. So all these can be symptomatic manifestations. Then what can happen is that the patient can develop anginal episodes. So see, dyspnea on exertion, you are clear, why it actually happens. You have a very small LV cavity, there can be back pressure. Okay, so there can be a bit of pulmonary edema as well contributing. And next is about the anginal episodes. See, anginal episodes, let me tell you, why does it occur is because, see, we have very less blood in the left ventricle, and you know that the coronary vessels, okay, the coronary circulation is again dependent on your cardiac output also, because that is where your coronaries will also get the blood supply. So because there is a decreased end diastolic volume, okay, the end diastolic volume is actually decreased, and because there is very less blood inside the ventricle, very less blood goes outside the ventricle during the systole also. So which means, the cardiac output also would actually decrease, and because the cardiac output is actually decreasing, there is decrease in the coronary perfusion as well. Okay, there is decrease in the coronary perfusion as well. And when there is a decrease in the coronary perfusion, that can actually predispose to ischemia, because already there is an increase in the demand. You should understand that there is a increased demand. Okay, there is an increased demand because of the increase in the musculature, but there is a decrease in the supply. Okay, so because of this mismatch of the increased demand but less of coronary perfusion, which means decreased supply, that actually can predispose to ischemia. So you can have subendocardial ischemia to begin with. Okay, you can have a subendocardial ischemia. So it is because of this the subendocardial ischemia, okay, as well as certain coronary microvascular changes are also contributing. Okay, so in addition to the musculature or the myocardial stress, okay, wherein the demand and supply there is no match. So in addition to that, there are certain coronary microvascular changes. Okay, there are certain coronary microvascular changes also happening, and these will actually predispose to anginal episodes. So you will get chest pain. Okay, all right. Next, patients may develop presyncopal or syncopal episodes. Presyncopal or syncopal episodes. So why does a syncope actually happen? Well, it could be because one reason could be the left ventricular outflow tract obstruction. There is a decreased cardiac output. So that can actually result in a presyncopal or a syncopal episodes. But more importantly, that can also occur because of arrhythmias. Okay, this can occur because of arrhythmias. So that is patients with this hypertrophic cardiomyopathy, when there is some subendocardial ischemia, this can trigger production of, result in arrhythmias. So arrhythmias means it can be arrhythmias like a ventricular tachycardia or a ventricular fibrillation. Okay, so VTAC or VFib. So that can result, and that can actually, maybe a transient episode of arrhythmia can result in a syncopal episode. Okay, so but remember, this is do not think that these arrhythmias would only result in syncopal episodes, because sometimes another arrhythmia that occurs in the same patient would even result in something that is known as the sudden cardiac death. It can result in sudden cardiac death. Okay, very, very important, because this is one imminent danger of this hypertrophic cardiomyopathy. This is sudden cardiac death. So in addition to VTAC and VFib, see what this VTAC and VFib is, that they actually appear transiently, okay, and go off. Yes, it can produce a sudden cardiac death, but if the examiner asks you a question like what is the most common sustained arrhythmia, okay, remember this word, sustained arrhythmia. What is the most common sustained arrhythmia associated with hypertrophic cardiomyopathy? Then your answer is not going to be a VTAC, because sustained ventricular tachycardia is not the one that is common. The sustained one is actually the atrial fibrillation. So many of the patients with hypertrophic cardiomyopathy may have atrial fibrillations. But most important, the dangerous one is the VTAC and VFib. Remember, when there is suddenly a ventricular fibrillation happening in an individual, remember, your heart is not able to contract well. So there is a hypoperfusion, and subsequently you can have a cardiac arrest developing in this patient. Sudden cardiac death can happen. Very, very important. Okay. So these are the important pointers, okay, about the clinical presentation of a hypertrophic cardiomyopathy. Very important. So I hope you are very clear with how a hypertrophic cardiomyopathy can present. Remember, it may not be symptomatic in all individuals. And also remember this point, that patients with hypertrophic cardiomyopathy would often have a positive family history. That is, maybe a particular individual, I'll tell you a classical scenario of hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy, often the clinical scenario that we commonly see, as well as the ones which are asked for your exam, is when you have a otherwise previously healthy individual. Okay, maybe he had some exercise intolerance but was taken lightly. So he plays some football match. So during the football match he is actually exerting too much, and while he is playing the sports, he might actually develop when there is a increased demand, you're further increasing your demand, right? When you're running around exerting so much, so when that demand actually goes high, there is an increased chance of ischemia, arrhythmias, and again sudden death. So he might just actually, during the time he actually plays, he might just faint down, and he might develop a sudden cardiac death. So this is very, very important, and this is often the clinical scenario that they will give of a young patient developing a sudden cardiac death, and they might ask you what is the possible cause. So the answer is a hypertrophic cardiomyopathy. That is a common one. See, the age is very important. In the same time, if you have somebody above 50 years of age, okay, developing such a sudden cardiac death, hypertrophic cardiomyopathy is not your first differential, because then you are likely to have a coronary artery disease. For that, do not write hypertrophic cardiomyopathy. For that, it is likely that the patient would have had atherosclerosis involving the coronary arteries, subsequent ischemia, and then sudden cardiac death. That is a possibility. But here, young patient, that is the catch point, young patient. But let me tell you one thing, that is hypertrophic cardiomyopathy exclusively present in young adolescents and young adults? I told you it is predominantly found in young adolescents and young adults, but this is one disorder that may be seen in other extremes of age as well. You can occasionally have a patient in the 60s, okay, 65, 68, 70 years developing hypertrophic cardiomyopathy, and because manifestation may be there. It is a genetic condition. Maybe during these years, he was relatively asymptomatic. Maybe in the 30s or 40s, he had some exercise intolerance, but he was not taken seriously. And he would have had an episode maybe when he is a 65 years age group. But the point I want to tell you is, when you have a patient with above 50, developing such an event, your first possibility should not be a hypertrophic cardiomyopathy, which is a structural heart disease. The possibility is likely a coronary vascular disease or a coronary artery disease, which subsequently led on to this complication. Okay, so always remember that. So young patient, especially with a family history of a sudden death, okay, in young age, that is again favoring a hypertrophic cardiomyopathy. Very clear. So after having understood the clinical presentation, let's move on to the examination findings. So in the examination findings, I'll tell you the important examination findings, especially this can come as a part of your exam question. So first of all, first point that you have got to know is about the pulse. So can you tell me what is the pulse abnormality that you see here? I have already taught you this in the pulse module. So what is the pulse abnormality that you can see associated with the hypertrophic cardiomyopathy? The characteristic pulse abnormality is known as pulsus bisferiens. Okay, pulsus bisferiens. So this is a pulse abnormality where you will have two peaks. Okay, it is an abnormality where you will have two peaks in systole. So two peaks in systole, that is what you are getting in pulsus bisferiens. I'll probably show you the picture. You see here, this is a patient with a pulsus bisferiens, that is a hypertrophic cardiomyopathy patient. You can see this is S1, S2, the period of systole, and you can see two peaks. The first peak here, peak 1, peak 2. Okay, this is your percussion wave, tidal wave, dicrotic notch. So two peaks in systole, that is what you get in pulsus bisferiens. Okay, that is the pulse abnormality in hypertrophic cardiomyopathy. So that is about the pulse abnormality. Then blood pressure, you are not going to get any significant change. Okay, it would relatively be normal. And then coming to the apex beat. Okay, apex beat. So apex, important point that you should know, a potential question also, is that you can get a double apex beat. Double apex. So which means probably you are getting a apex beat in two intercostal spaces. So what magic is this? You are getting two apex beat. See, why you can feel this apex beat in two intercostal spaces, that, see, one is your usual apex beat that occurs in your systole. The second is that you will have a possible apex beat that occurs in the diastole. So the reason is because, see, I already told you that the left ventricular cavity is small. So you will have a left atrial hypertrophy. So the left atrium, it is actually contracting with increased force because it has to pump against a hypertrophied left ventricle. So when this left atrium uses all its force, because you know that the atrial systole actually happens during the ventricular diastole. So when this atrial systole actually happens, because a strong atrial systole happens, that pressure is actually transmitted, and in diastole also you can have a apex beat. Okay, so that is what you call a double apex in case of your hypertrophic cardiomyopathy. Very important. And also you can get a sustained apex also, okay, because there is a good degree of hypertrophy. You can get a sustained apex beat also in case of a hypertrophic cardiomyopathy. Very, very important. Okay, so that is also important. So pulse finding I have told you, apex finding I have told you. So coming to the heartbeat, the heart sounds. So heart sounds in case of hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy heart sound, very, very important point is that you have got to know the peculiarity of the second heart sound that happens, because normally you know that there is a A2 P2, okay, So between this aortic and the pulmonic components, there is a A2P2 gap. So this particular gap that you see between the aortic and pulmonary, so this gap, what will it happen in case of a hypertrophic cardiomyopathy? See, remember there is a left ventricular outflow tract obstruction. So the aortic component would be delayed. You agree with me? The aortic component will be delayed and it will actually subsequently move very close to the pulmonic component. So the S2 split, what you can have is that you can have a initial split will actually become narrow. It actually becomes narrow, and subsequently what happens is that when the split actually further narrows, you can either get a single second heart sound or a reverse or a paradoxical split. Okay, so initially is a narrow split, then you can have a single S2, and subsequently this can move on to a reverse split or a paradox split. Okay, so that is what happens to the second heart sound in case of your hypertrophic cardiomyopathy. Very, very important point. Often this is asked. Okay, most often once it actually becomes hemodynamically significant, it actually goes for a reverse split. Okay, so next is regarding the S4. Okay, you will get because of these. Why do you get S4? I've already taught you in the heart sounds. See, you get an S4 because of this strong left atrial contraction. You have a hypertrophied left atrium contracting, because of which you will have a S4 heart sound. Very, very important. Okay. An additional auscultatory finding is that of an ejection systolic murmur. Ejection systolic murmur over the aortic region. So this ejection systolic murmur of the hypertrophic cardiomyopathy is very important and is quite distinct from the ejection systolic murmur that you see with aortic stenosis. So how is it different? Well, this ejection systolic murmur of HCM is in fact increased in intensity by maneuvers that will decrease the preload, decrease the afterload, and increase the myocardial contractility. So whatever maneuver is going to decrease your preload, decrease your afterload, or increase the myocardial contractility, all this will result in what? An increase in the left ventricular outflow tract obstruction. So this will increase the left ventricular outflow tract obstruction, and hence it will increase the severity of symptoms, increase in the severity of symptoms of hypertrophic cardiomyopathy, and also it would result in increase in the intensity of murmur. Very, very important. Okay. All right. So when you talk about decreasing the preload, please understand that when you do Valsalva as well as on standing, see, the venous return to the heart is actually decreased, and normally maneuvers that will decrease the venous return to the heart usually decreases the intensity of various murmurs. But hypertrophic cardiomyopathy, there is an increase in the intensity of the murmur, which is very important, often asked in exams. So Valsalva and standing increases the intensity of murmur by increasing the left ventricular outflow tract obstruction. And also you have certain drugs that would again decrease the preload, like your nitrates, drugs like nitrates, diuretics, as well as AC inhibitors. AC inhibitors will decrease the afterload also. So the importance is that these drugs should not be given in patients with hypertrophic cardiomyopathy. So is the case with drugs that decrease the afterload, like say amlodipine. So amlodipine is a dihydropyridine calcium channel blocker. So this will act on the blood vessels mainly. So it will decrease the afterload, hence will increase the left ventricular outflow tract obstruction. And drugs increasing the myocardial contractility like digoxin also is to be avoided. So this is an important question. They might ask you which of the following drugs should be avoided in patients with hypertrophic cardiomyopathy. Always remember nitrates, diuretics, AC inhibitors, amlodipine and digoxin. Very, very important. So this can be asked as a question. Okay. So that's about the ejection systolic murmur. Just know one more point, that sometimes associated with SAM, you may have a mitral regurgitation murmur. That is, a murmur of mitral regurgitation may be there. That is, you might get a pan-systolic murmur over the apex. So that is also possible. Okay, pan-systolic murmur over the apex. So usually you get the ejection systolic murmur. You may also get the pan-systolic murmur. Okay, so after having seen the examination findings of hypertrophic cardiomyopathy, let's move on to investigations. So what investigation are you going to do to confirm your diagnosis of hypertrophic cardiomyopathy? You are going to do a transthoracic echocardiogram. So what are you going to see in the echo? Number one, you're going to see that there is a diastolic dysfunction. There is asymmetrical septal hypertrophy. Okay. And also you're going to see systolic anterior motion of the mitral valve leaflets. These are the important echocardiographic findings. So if you look a picture of the echo finding, this is just a demonstration of the hypertrophied septum, which you can see, and you will also be able to see the systolic anterior motion of the mitral leaflet, also the left ventricular outflow tract obstruction, which is dynamic, very, very important. So these are the echocardiographic findings. Remember, that is going to be the investigation of choice. Okay, all right. So next, what will happen when you take the ECG? Yes, who's going to tell me what is going to happen when you take the ECG? What are the findings that you expect? When you take the ECG, I'll just show you a sample ECG of a patient with hypertrophic cardiomyopathy. See, always remember, one finding that you will definitely get is that of a left ventricular hypertrophy. And what is the objective evidence of a left ventricular hypertrophy? Well, the depth of S wave in V1 plus the height of R wave in V5 or V6. So this actually goes above what? 35 millimeter. So that is when you say that there is evidence of left ventricular hypertrophy. You may also get other findings like deep T inversions. You may also get Q waves in the inferior and lateral reeds corresponding to the septal ischemia. Okay, and some patients you may also get atrial fibrillation, because remember I told you atrial fibrillation is the most common sustained arrhythmia that you will see in case of patients with hypertrophic cardiomyopathy. So here, in the ECG that is given, you can see evidence of left ventricular hypertrophy, which is quite obvious, and you can see the T inversions as well. It is not necessary that atrial fibrillation is there in all cases, but again, most common sustained arrhythmia, if present, is going to be atrial fibrillation. Okay, all right. So that is your ECG. Then you can even go for your Holter. Okay, to detect arrhythmias, you can go for Holter examination as well. Then another investigation that is coming up in a big way is the cardiac MRI. So you can go for the cardiac MRI as well. Okay, and then see, one important MCQ point is that when you do a cardiac catheterization, okay, so remember, this is an invasive procedure. So I'm just telling it because there is a potential question in that. So when you do a cardiac catheterization in a patient with hypertrophic cardiomyopathy, there is one sign that you should know when you study the pressure dynamics. So that is referred to as a long name, okay? Broken bro, Braunwald, Moro sign, okay? Okay, a long sign, okay? So what is this particular sign? See, when you do cardiac catheterization and whenever there is a premature ventricular contraction, okay, suppose the ECG is showing a PVC, premature ventricular contraction. So normally after premature ventricular contraction, what should happen, normal individuals, what should happen is that you have a end diastolic volume increase, okay, more time for the ventricle to fill, and subsequently as per the Frank-Stallings law, more of force of contraction, hence the pulse pressure should normally increase. Pulse pressure should normally increase, okay? But in case of hypertrophic cardiomyopathy, the point I want to stress is that there is a paradoxical decrease in pulse pressure following a premature ventricular contraction, okay? So this is what is called the Braunwald Moro sign. Very, very important, okay? They may ask as a one liner, okay? But you know, the name itself would consume a good part of the question, so I'm sure the examiner would think twice before putting this. So that is this sign, very, very important. The reason is nothing but it increases the left ventricular outflow tract obstruction, okay? That is the reason for this sign. So these are the important investigations in case of hypertrophic cardiomyopathy. Okay, very, very important. Now let's move ahead with the treatment of hypertrophic cardiomyopathy. Treatment of hypertrophic cardiomyopathy. See, the treatment of cardiomyopathy, hypertrophic cardiomyopathy, the latest guidelines is the 2020 guidelines of the American Heart Association and American College of Cardiology. So that is the guidelines which was published somewhere in November 2020. So we're going to see the most important points of these guidelines only. And you needn't know each and every details of the guidelines, but whatever is important for your exams, I'm going to teach you. So regarding the treatment of hypertrophic cardiomyopathy, imagine if the patient is symptomatic, okay, because I have already told you a good number of patients would be mostly asymptomatic. But if the patient is symptomatic, always remember the first choice drug will be beta blockers. This is a potential question. Hypertrophic cardiomyopathy, medical management, what is the first choice drug? It is going to be beta blockers. So when you use beta blockers, what is it going to do? This is going to decrease the heart rate as well as it will decrease the oxygen consumption. So is this a favored action or not? This decreasing heart rate and decreasing oxygen consumption in hypertrophic cardiomyopathy, it is a desired action, okay? Why is it desired? Because you know the already muscular hypertrophied ventricle is consuming all these oxygen. So that is predisposing to various complications. And yes, beta blockers by decreasing the heart rate and by decreasing the oxygen consumption has a favorable profile. Okay, so you can use beta blockers. Then the next drug that you may use is verapamil, which also increases the AV nodal conduction time. So verapamil can also be used. But always remember, you see the important point here. A calcium channel blocker like verapamil can be used in the treatment of hypertrophic cardiomyopathy, whereas amlodipine, which is also a calcium channel blocker, is contraindicated. The basic reason being verapamil is a non-dihydropyridine calcium channel blocker, so it is predominantly acting in the heart, unlike your amlodipine which acts on the vessels. So that is why your verapamil can be used, but amlodipine is contraindicated. Very important. So verapamil can be used, and the next drug that can be used, very important, is disopyramide. See, disopyramide is often used as an add-on combination to the beta blockers or verapamil. So this drug also will help you in decreasing the left ventricular outflow tract obstruction. Okay, so thereby this is also a good drug that can be used. So these are drugs which can be used in the medical management. And what if the medical management fails and the patient is still symptomatic? What are you going to do? In that case, the next step is that if the patient is fit for a surgical procedure, you will go for a surgical myomectomy or myectomy, you can call it. So what you do is that your villain, the the septal hypertrophied muscle, some part of this is actually removed. Okay, so that is what is done in case of surgical myomectomy. You can also go for an alcohol if the patient is not fit for a surgery. You can also go for an alcohol-based septal ablation, where injection of alcohol can result in ablating the hypertrophied muscle. So what is the advantage of doing this surgical myomectomy? I'll just show you a picture here. So just observe the picture which I'm going to show you. Okay. So this is a patient with hypertrophic cardiomyopathy, and this is a post myomectomy. What you can observe here is that, see, first of all, look the region around here. You can see that it is very much narrowed. The left ventricular outflow tract is very much narrowed, and you can see the anterior mitral leaflet almost kissing your hypertrophied septum. But when you do this myomectomy, a part of the myocardium being removed, you see how much it is improving the outflow tract. You know, you are now having a very good outflow tract. Okay, so that will actually improve the symptoms. And remember, doing a myomectomy in fact will indirectly improve the better the systolic anterior motion as well. So that also will not happen when you are doing a myomectomy of a patient with hypertrophic cardiomyopathy. Thereby it will create a favorable outflow tract. Okay, so that is your surgical procedure. If not fit for the procedure, you will go for an alcohol based septal ablation. Now the point is, this is the management of symptomatic patients. Okay, so there are certain scenarios where you will have to go for an ICD. Okay, that is an implanted cardioverter defibrillator. You have to go for an ICD. So ICD is actually given or is actually put if the patient is having any of the risk factors for sudden cardiac death. Risk factors for sudden cardiac death. So if the patient is having risk factors for sudden cardiac death, that is when you will go for an ICD. So what are these risk factors? Remember, this is very important. This is given in a table in Harrison, which makes it all the more important. So from the history, if the patient is having a history of a cardiac arrest or a spontaneous sustained ventricular tachycardia, definitely that is a high risk for developing sudden cardiac death. So is the history of a syncope. See, the patient actually gives a history of syncope. You know, it probably has come for some medical checkup. You examine and you find auscultatory findings suggestive of hypertrophic cardiomyopathy. You take an echo and again it suggests hypertrophic cardiomyopathy. And the patient in history itself is saying that he has had a history of syncope, maybe 2 or 3 episodes. Definitely you have to put a ICD. Now, if the patient asks, doctor, you know, I've just had some syncopal episodes, why should I go for ICD? You should say that, you know, you should be thankful to God that the initial episodes were restricted to syncope. Next episode, you know, you might even develop a sudden cardiac arrest. So it is very important that you put an ICD. And if there is a family history of sudden cardiac death, that is also important. And remember, if there is also a spontaneous non-sustained ventricular tachycardia as defined by more than 3 beats at a rate of more than 120. So if there are such spontaneous non-sustained ventricular tachycardia, then also you will have to take it as a risk factor for sudden cardiac death. Then if the left ventricular wall thickness is more than 30 millimeter. See, one point that you have got to know is that normally in the diagnostic criteria of hypertrophic cardiomyopathy, to call it HCM, the left ventricular free wall must have a thickness of more than 15 millimeter. Remember, it's not the septal wall thickness, though that is usually the septal wall that predominates, but in the criteria, the free wall more than or equal to 15 millimeter, or even if it is more than or equal to 13 millimeter with a positive family history. Okay, with a positive family history, that is when you can diagnose it to be a hypertrophic cardiomyopathy. But if the wall thickness is more than 30 millimeter, okay, so if it is that huge, then again a risk factor for sudden cardiac death. And another risk factor for sudden cardiac death is an abnormal blood pressure change in response to exercise. That is, normally when you do an exercise, you expect the systolic BP to go high. Suppose, the systolic BP remains normal or it falls. Okay. So if there is a fall or a failure to increase at the peak of exercise, then again it is indicative of a risk factor for sudden cardiac death. So all these risk factors are very, very important. It can be asked as a question. Please learn it well. Okay, it has been previously asked also. So these are the risk factors for sudden cardiac death in patients with hypertrophic cardiomyopathy. And if there are such risk factors, go for an ICD. Clear? Okay. Now, next scenario is if the patient is asymptomatic. Okay. So I'm just giving you a scenario like, say you have two siblings, one of them had developed a sudden cardiac arrest. So he expired at 25 years. So the other sibling, is having a doubt whether he also is at very high risk. So definitely, it is an autosomal dominant condition. He is also at increased risk. So you do a ECG and an echo, you find that at present he is not having symptoms. So what will you do in this patient? Will you just send him saying that as of now you look perfectly fine, so you go back home, there is nothing to worry? See, there is one thing here that you should tell the patient that as of now, okay, as of now, you are not having any obvious features of a hypertrophic cardiomyopathy. But remember, I have already taught you this, that hypertrophic cardiomyopathy can occur in a varied age group. So sometimes he can present in the 30s or 40s. So you tell this patient, see, I want you to follow up at a gap of around say 2 to 3 years. So every 2 to 3 years minimum, you should pay you must actually have a follow-up visit. And when you have a follow-up visit every 2 to 3 years, I will check your ECG and I will check your echo. So you'll check your ECG as well as echo, and you have to periodically monitor him. Okay. So if he develops any symptoms, then you have to go back to the medical management. Otherwise, you keep on following. But it is very important to keep the follow-up. So that is how you will manage patients with hypertrophic cardiomyopathy. So this topic, hypertrophic cardiomyopathy, is a very, very important topic. Okay. If I am asked to put one question on cardiomyopathies, I'll put a question on hypertrophic cardiomyopathy. It will be a clinical scenario where I'll give you either a scenario of a sudden cardiac death, asking you the possible diagnosis, or maybe an individual who was probably screened in a medical camp, found to have some auscultatory findings suggestive of hypertrophic cardiomyopathy. And then maybe based on whether he is symptomatic or asymptomatic, I might ask you the management. But all in all, a very, very important module. Learn it very, very well. Okay.